Ziad is, I'm learning, kind of an interesting guy. He is a trained physician and clinician and still gets away to do emergency medicine once in a while. And somewhere along the way of his training, he picked up economics and machine learning and now does more than a bit of that as well. Ziad's going to talk to us today about two topics that I think are some of the most kind of fascinating, consequential in this world that we're all interested in of the digital economy. It's the comparison between human expert clinicians versus algorithmic predictions, and at the same time, this issue of algorithmic bias that we are all justly so concerned about. So, Ziad, over to you. Thanks for joining us.
Thank you so much for the invitation, and so happy to be here. So let me launch right in. So this is going to be work I do, as Andy mentioned, have some work on algorithmic bias, but most of my work is actually much more optimistic because I do fundamentally believe that algorithms are going to be a huge part of medicine over the next few decades. And so this work is part of at least the early part of our vision for where algorithms can help doctors in ways that I hope will be both useful and interesting. So I wanted to start with a topic that Andy alluded to, and I know is core to what the people in this room think about a lot, which is the right way to get this human-machine interface working in health as well as everywhere else. So there are some well-known models and like templates for thinking about that. One of them is automating the doctor, so where the algorithm is basically substituting for parts of what the physician does. And the other one is kind of an augmentation one, which is now a little bit trendier and more popular, where the algorithm is kind of like a helper and a complement to the doctor rather than a substitute. And so I'll have some things to say about both of those models and at least what I've learned about them from doing this work. But I want to actually focus on a third way that I'm increasingly thinking about algorithms in health and in other fields, which is as tools for learning about complex systems. And so what I'll try to convince you of today is that machine learning is a very, very powerful tool for learning about the specific nature of inefficiencies in health in ways that we haven't previously been able to appreciate. And also really important ways that we can get inside the physician's head and learn how physicians think. So with that brief introduction, let me launch right into the specific use case. So as Andy mentioned, I trained in emergency medicine. And one of the very common dilemmas in the ER, but also in lots of other parts of the healthcare system, is patients who come in with vague symptoms like a little bit of chest pain or some shortness of breath or nausea or a bunch of these things, which actually can be consistent with a heart attack. So one of the things that you learn in residency is that they don't always look like they do on TV. It's not always someone, like a middle-aged white man coming in and clutching their chest and saying, I feel like there's an elephant sitting on me. Most heart attacks actually have very subtle symptoms and so require a lot of care. So there's a lot of people that come in with those symptoms. And there are tests that we can do to definitively diagnose heart attack. Those tests are, I'm going to talk about a group of tests, but the one that you should think about most is catheterization. So a catheter is inserted in one of the major arteries of the body, and it's snaked all the way up into the heart, where you can get into the coronary arteries that supply the heart muscle with blood and visualize a blockage. So that's the test. That's also the treatment, because then when you find the blockage, you can open it up with a little stent. But that's, as you can imagine, expensive. It's an invasive procedure. It's expensive in terms of just cost, but also in terms of the risk that you're exposing the patient to in the hospitalization. And so there's this terrible situation where there's a ton of patients who look like they might need testing because a lot of people have these symptoms, but you have this limited resource of the test. And so you're facing this trade-off between, like, if I test more people, I'm going to catch more heart attacks, but I'm going to waste more resources, but I really don't want to miss a heart attack. And so the tests are, as I mentioned, catheterization, and then there's an intermediate step that's like running on a treadmill. If that's positive, then you still have to go on to catheterization to get the heart attack treated. So I'm going to refer to those two together as tests. And the thing we're testing for is a blockage in the coronary arteries that leads to all of these downstream complications or even sudden death. And so that's what, when people talk about heart attack, colloquially, they mean a blockage in the coronary arteries. These are the tests that do it. So the ER doctor is looking at this mass of patients coming in and trying to sort them, at least on this on this dimension and figure out who's the high risk population that I need to test and expose to all these risks in order to diagnose heart attack. So that's the setup. And I'm just going to kind of make explicit the way we kind of think about our model of testing, which is that patients come into the ER and each patient has some probability of blockage based on two sets of variables, X and Z. X are the ones that we see as the policy planner, the researcher, and Z are the ones that the physician sees and we don't see. So Z is like the private information about the patient that the physician has and we don't, and X is the shared information set that we both have access to. So for any given patient with any likelihood of blockage, if they are tested and they have a blockage, then the blockage gets diagnosed and treated, and the patient gets huge health benefits. So there's decades of randomized trials that show that if you have a blockage that is a new blockage and you come into the ER with this new symptom and you get your blockage opened up, there's a huge return in terms of just life years and quality of life saved. If you have a blockage and you're untested, though, you are going to have that blockage missed. So you're going to be diagnosed with something else, or you're going to be sent home. And that's going to lead to an increase in your adverse event risk. And those increases in risk are well mapped out by another clinical literature that before we ever had treatments for heart attack, just looked at what happened to people after heart attack and showed an increase in sudden death, arrhythmias like ventricular tachycardia, ventricular fibrillation, and downstream consequences like heart failure and functional limitations and pain. So that's the situation if you have a blockage. Now, if you're the social planner, there's a very clear optimal testing rule, and that is to say, okay, I am going to define a threshold for testing people based on their likelihood of blockage. And I'm going to test everyone above that threshold and nobody below that threshold. And the reason that this is clear, at least in our model of testing, is because only positive tests have benefits. So if someone has a blockage and they get a test and that test is positive, they're going to get these huge returns to treatment. If the person doesn't have a blockage and they get a test, that test is basically wasted. Now, there's an asterisk there, which is like maybe there's a psychological benefit to knowing you didn't have a heart attack. Maybe it helps the doctor kind of like refocus on other things that the patient might have. We're going to consider that in isolation, and we're only going to look at the health benefits. And we're going to say that negative tests have only costs. You've exposed the patient to the risks and the costs, the financial costs of testing, and you have nothing to show for it because you're back to where you started before you ever did the test. And now you need to figure out what the patient does have rather than what they don't have. So test everyone whose likelihood of blockage is above a threshold that's based on the costs and benefits of the test and the treatments that patient gets. So that's the socially optimal rule. And there's a difference between the socially optimal rule and the physician testing rule that's actually being used in the ER. And in fact, there are two differences there. The first difference is that the physician does not have access to the true likelihood of blockage function B. The physician is using some function H of X comma Z, which is the intrinsic risk prediction kind of software that we doctors are deploying in the ER to predict the risk of blockage. And so that H of Z, H of X comma Z might not be the same as B of X comma Z. And so you can get some distortions there. And the second one is because physicians might also have some private incentive to test. And so that, whether that's positive or negative in the moral hazard view, it's typically a positive incentive to do more stuff because you're paid by the stuff. That's going to lower the threshold to doing a test. And that's also going to introduce a distortion relative to the socially optimal rule. Let me actually just pause there for a second. And you're all being extremely nice and not interrupting me, but I did want to give anyone a chance to ask questions about the setup, because as you know, once you've accepted the setup, it's all over after that.
May I make one quick question?
Absolutely.
I'm concerned about your socially optimal test because it is easy to imagine scenarios where negative tests generate externalities of insight about populations, etc. And the second, of course, is you're leaving out the confusion matrix aspect of it, i.e. false positives and false negatives. And I would sort of like to see those accounted for when you're coming up with a model like this.
Yeah, thanks for asking. So there's a lot more detail on this in the paper, but let me briefly say two things. I'll start with the second one, which is that tests are not perfect. And so you're exactly right. The tests have false negatives and false positives. In practice, we can actually account for that directly in the cost-benefit analysis, because there's a certain likelihood that a person with a blockage is not going to get treatment because of that false negative risk. And then there's a certain probability that people without blockage are going to get tested, and that's the false positive risk. And so all of that can actually just be handled in the usual way that this literature handles cost-benefit analyses. So that is accounted for. Now, your first point, oh, sorry, was there another?
Results we should give.
Sorry, if there was a question, I couldn't quite hear it. Okay, let me move on to your first point. So you're absolutely right that there's an externality to doing a heart attack testing in terms of the testing that you might do for lots of other stuff. So that is something we do not account for. And the way I would think of that is that, you know, each diagnosis that the doctor is trying to make has its own budget. So there's like a testing budget, and there's kind of like a health return. And so if I had a prior distribution over all these diagnoses, now I've gotten my heart attack from very low down to 0. And so you're right that that adjusts upward mechanically all the other things, but it doesn't actually give you more information about the other things. It just makes all of them much more likely because you've eliminated this one. So you're totally right, and I think that is something we don't account for, but I think you'd still have to account for it separately in all of the other diagnoses and tests that you're considering.
Thank you.
Any other thoughts or questions? Okay, please don't hesitate to interrupt. Moving on. So given that setup, that implies a few empirical tests that we're going to be able to do, which start with the observation that is not very interesting, that any set of patients defined by X and Z are either above or below the threshold for optimal testing. We're going to define over-testing as any such set of patients who are tested, but then go on to have a yield of testing in terms of, like, you know, the treatments they get and the benefits below a threshold, which is the kind of optimal threshold based on the costs and benefits of the tests and the treatments that come out of that test. So if that set of patients is below that threshold, then eliminating all of the tests in that set is going to increase welfare. So we're not saying that each individual patient is over-tested. We're saying that the set of patients is on average over-tested. And so if we eliminated all those tests, we'd be better off, even if there's some variation in the actual individual risk. Correspondingly, under-testing is the mirror image of that for the untested patients. So if you have a set of patients who is untested, but goes on to have an adverse event rate above a threshold that suggests that they had a high likelihood of heart attack, and then went on to have these high adverse event rates, then that set is going to be undertested. And that threshold is going to be set based on some very widely adopted clinical guidelines for testing for heart attack. So in lots of health systems and hospitals, there are these clinical decision rules that try to help doctors figure out whom to test. And the way they define sets of patients who are tested is ex post with respect to their adverse event rate. And these are those well mapped out adverse events that come from missed heart attacks. So there's some base rate, but when those rates go above a threshold, it suggests that that population of patients had a high rate of untreated heart attack, and they went on to have adverse events as a result. So just as, you know, over-testing means we should eliminate all those tests, if a set of patients is undertested, then testing everyone in that set would increase welfare. So a couple of things to tie this back to the model. If we have incentives distorting the physician's testing function, and those incentives follow the standard moral hazard, you know, view that physicians have a positive incentive to do more tests, and there's some variation in that, you would only get over-testing, because that's just going to move the threshold down, but it's not going to do anything to the ranking. If you have misprediction, in other words, if the human risk prediction doesn't match the true risk prediction, then you can get both, because that can just distort unpredictably people being over or underestimated and over-ranked or under-ranked in the testing distribution. So those are the tests that we're going to do to look at inefficiencies in physicians' decision-making. So you can probably see where machine learning is going to come in here, because this is a good prediction problem. So we're going to form explicit predictions on someone's risk of blockage using machine learning. And we're going to use the output of that algorithm to find subsets of patients where there might be mistakes based on X and X alone. So we are just using the algorithm to identify sets of patients. We are not using the algorithm as an arbiter of truth. We're not assuming that the algorithm is right. So if we see that physicians are doing something that's different from what the algorithm would have predicted, we don't assume the algorithm is right. And that's a really important point, because physicians have a huge informational advantage based on Z that the algorithm does not have access to. And as I'll come back to, Z is very likely to contain signals for risk and for treatment benefit that the physician is using effectively and that the algorithm cannot use. So we can't just assume that the algorithm is right when it suggests something different from what the physician is doing. Instead, as I showed you in those empirical tests, we're going to identify actual errors using patient health outcomes, not by assuming that the predictions are right. In the tested, we're going to use the observed yield of testing. In the untested, we're going to use the adverse event rate. And we're going to compare both of those to establish thresholds of either cost effectiveness or adverse event rates from the clinical literature. So we're not imputing any outcomes here. And I think that's one of the really important points that, or one of the problems that I think was important to solve for this paper. So I'm going to not get into a lot of the details of the prediction, very happy to do that later. But at a high level, if you imagine the patient coming into the ER at time 0, we're going to divide the timeline into before and after. So over the 2 years before the patient walks into the ER, but including what the patient says at the triage desk, like I have chest pain or I have toe pain, we're going to construct a bunch of variables that are going to be the inputs to the machine learning model. So we end up with about 16,000 variables because we've got lots of diagnostic codes, procedure codes, labs, vital signs, et cetera, et cetera, et cetera. So there's lots of inputs. And then over the 10 days after that visit, we're going to observe who gets tested and who gets treated for heart attack in the wake of one of those tests. So that 10-day period is based on clinical guidelines for, like, you know, what is the maximum amount of time that if you're worried about heart attack, a patient should be referred to testing. This goes back to that point that not all heart attacks are these, like, you know, patient is crashing, need to get them immediately to the catheterization laboratory. Most heart attacks are actually much more subtle. And so the clinical guidelines are, you know, you should probably do this within 48 hours, and the most lenient guidelines are 10 days. In practice, most of our tests, the vast majority, come in the first 48 hours after that ER visit. So where are we doing this? We're doing this in the electronic health record system of a large, top-ranked academic hospital in your neighborhood, where we see a continuous census of everyone who comes to the ER. So it's about 250,000 patients over a 3-4 year period. And we're going to remove anyone who, coming into that visit, has some indication that maybe, like, they wouldn't necessarily benefit from testing, and so physicians might not want to test them. So we're going to take out anyone 80 years old or above, take out anyone with cancer, end-stage heart failure, things like that, anyone who's been in a nursing home or is on hospice or things like that. So we're going to do our best to remove anyone who might be too frail to benefit from this procedure. And then in the remaining set, we're going to train a model based on a 3/4 random sample of patients. And so all of the visits from a patient either get into the training set or the holdout set. We're going to predict in the tested the yield of testing as a proxy for blockage. And then we're going to show you the results. All the results I'll show you is from this 25% holdout set that the model has never seen. So that's the algorithm. But as I emphasized before, we're just using this algorithm to identify sets of patients with observable characteristics that might be over or under tested.
Ziad?
So, yeah.
Quick question on the exclusions. Do you, so Emma's asking, do you remove diabetics?
No. No, so we want to exclude people that ex ante physicians might be reluctant to test because they're, like, too frail to tolerate an invasive procedure, or the procedure might cause more harm than good. But diabetics as a whole are actually people who would benefit a lot from this procedure. So we don't take them out. We're trying to just get the frail people out, not, just like, come up with a set of totally normal people. So here's the first set of results from the tested people. So in the holdout set, we bin the people that ended up getting tested by the physician into deciles, so 10 bins from low risk to high risk. And on the y-axis, I'm showing you the yield of testing in each bin. And the average yield of testing is 14%. So everyone who gets tested, physicians have a hit rate of like 14%. Now, because these treatments that come out of testing are so cost effective in terms of life years saved, this ends up looking like a cost effective status quo, where we're below the typical threshold of like $100,000 per life year, looking good on that margin at $89,000 per quality adjusted life year. But there's a lot of heterogeneity. So in the lowest bin, you're at like over $1 million per life year. And in the highest bin, you're very cost effective at like 50, over 50% of people end up having a heart attack and being treated for it. And that's very cost effective, even by UK or European standards, not just the big spenders here in the US. Now, so that's kind of like, there's high value testing and there's very low value testing. And what we can do is we can generate predictions. So this is just the tested people. We can generate model predictions for untested people too. And we can then use that to ask the question, okay, the model thinks that people at this level of risk in that top decile are going to be super cost effective to test and then treat. What fraction of people with that level of observable risk actually get tested? And it turns out that only about half of people get tested. So the fact that 50% of these very high risk people are untested might look like undertesting. But because of selection into testing, we cannot use that fact to conclude that physicians are undertesting. So yes, physicians are failing to test apparently high-risk patients, and I think that's been shown in this really nice paper by Jason Abelak and Leila Aga on testing for pulmonary embolus. But unfortunately, physicians might leave some of those people untested for good reasons that we don't see. So imagine a diabetic person coming in with chest pain. The model is going to say, wow, this person looks like really high risk, but then they go on not to be tested. What we don't see is that the physician opened up their shirt and saw that the patient had a huge bruise on their chest, and that's why they had chest pain. So high-risk people don't necessarily have blockage, and the physicians see a bunch of signals like that. And there's kind of a basic econometric problem, which is that in the tested people, that's fine because we see the test result and we know who is right. In the untested, we don't have that definitive test result. So we're going to look at that these two other strategies to make sense of what's happening in the untested. The first one is we're going to look at the adverse event rate and compare that to clinical decision rules. And the second is we're going to exploit a quasi-experiment that's going to exogenously move testing up or down so that we can directly measure the impact of testing on health. So let me first show you those adverse event rates. So again, this is now in the untested patients. We've binned them by risk on the x-axis. And the y-axis is the adverse event rate. And that is people who came back in the 30 days after their ER visit and needed to have urgent treatment for a heart attack. We confirm all these heart attacks with biomarkers of heart attacks, so we're not just relying on ICD codes. We also include cardiac arrest, and we also include death, which we ascertain by linking to Social Security data. So we capture out-of-hospital deaths, which is really important. And what you can see is in that top bin of predicted risk, the adverse event rate is 16% at 30 days. The clinical threshold that recommends testing above a risk of X is 2%. So these high-risk people have a huge rate of adverse events, way in excess of what the clinical guidelines recommend. And it's not just diagnosed events, it's also death. So death is about a third of those adverse events in 30 days after people were tested. So what that tells us is that those high-risk people are truly high risk. This isn't that bruise on the chest situation where the physician actually knows that they're lower risk. These people are genuinely high risk as manifested in their adverse event rate. But that doesn't exclude another kind of private information, which is that physicians may know that they're high risk, but they might decide not to test because they don't think the patient's going to benefit from treatment. So we've tried to kick out, older people, end-stage illness, et cetera, but that's just based on X. So there could be people that we haven't managed to exclude. So an insight here is that physicians, we see everything the physician does in the ER because we have all the orders that they put in. And in that set of actions, the physician tips her hand about what she's thinking. And specifically, there are these two very low-cost screening tests that we use as a proxy for the physician's suspicion for risk. Now, importantly, these two tests, the electrocardiogram, the ECG, and troponin, which is a lab test, they're done on everyone, even people that the physician has a very low suspicion of heart attack. And they're done even on people that you're not going to send for invasive treatment, because you still need to know if they're having a heart attack, the severity of the heart attack. Do you send them to the ICU? Which medications do you give them? So when the physician is thinking heart attack, it would be unthinkable for her not to order these two tests. So we're going to use that to actually look at people who don't have those two tests, where the physician is not suspecting heart attack, and lower bound the adverse event rate in unsuspected patients, where we know the physicians are not aware of risk and have private information about lack of benefit. So if we find a high adverse event rate in untested and unsuspected people, we know that that's not private information. That's genuine error. So let me first show you, for those two tests, the fraction of people who are untested and don't have those tests. So this is like the untested and unsuspected population. And you can see both those lines point down in predicted risk. But in the highest risk bin, that's at the far right, these are people that the model thinks are very high risk, but there are still 19% of them who don't have an ECG and 41% of them who don't have the lab test for heart attack. So even though we see that physicians are testing, using these tests more in the high-risk people, there's still a substantial fraction of them that don't have those tests. And then we're going to look at the adverse event rates in those untested, unsuspected people. And we're going to find that the high-risk patients are still way above that threshold. So in the no ECG population, 5% go on to have an adverse event, even though the physician didn't test and didn't suspect heart attack. And in the no troponin population, the adverse event rate is even higher. Again, significantly above that clinical bound of 2%. So when we lower bound that, even in these unsuspected patients, we're still seeing that the model is finding people where the physician has made a mistake. So all that is, I'd say, suggestive, maybe circumstantial evidence. And it would be nice to have more direct evidence. And so ideally, you just want to take that high-risk group and randomly test them and measure the improvement in health outcomes when you test people more. So we're actually doing a randomized trial of this algorithm now.
May I ask a quick question on this?
Sure, yeah.
I'm old enough to remember when people talked about evidence-based medicine. What you have identified here is exactly the sort of thing, with apologies to Atul Gawande fans, this strikes me as a checklist kind of issue. Why is this not a part of a checklist? Are there medical systems that actually do what you've done and that you've had to adjust for that because it's not on the checklist? Because this is unambiguous stuff. This is fairly straightforward. It's the kind of thing you can turn into a rule.
So I'm gonna, let me come back to that question in a few slides, because doctors are absolutely using checklists. And so all of these decisions that we're seeing here, the testing decisions, are net of those checklists. They're very widely deployed, including in the ER that we're studying here. Doctors are using them, and yet they're still failing. And I have some evidence on why that's happening, but I'll come back to it in a couple of slides if that's okay.
Of course, thank you.
All right. So short of a randomized trial, we're going to use the insight that because people are variable, depending on the exact minute that you walk into the ER, you're going to see a different team of providers at the triage desk. That's nurses and a doctor during the day. And those teams end up testing patients at very different rates, conditional on risk. So when we look at high versus low testing shifts, we see that observables are balanced, including age, but also risk and sex. When we look at the yield, conditional on risk, we are not seeing that the high testing shifts have higher yield, implying that they're using private information. The unobservables also appear balanced across shifts. And at any given test rate, there's a ton of variation in the riskiness of patients coming into the shift. So this does look like a pretty good natural experiment where we can look at the effect of testing on health outcomes. And so here's one data point, which is that we're going to just run our bad outcomes over the next year. And I'm going to focus in on that last column, which is death over the year after visit. And I'm going to run that on patients' predicted risk according to the algorithm and the shift testing rate. And what you can see is that, superficially, this just looks like the standard diminishing returns, like flat of the curve healthcare. You test people more and they do the same. Like they don't do any better when you come into the high testing shift versus the low testing shift in terms of death over the next year. But that is very heterogeneous by patient risk. So the next regression interacts the testing rate and the risk. And what you can see is that now there's a very large and very significant interaction term between testing more for high risk people actually has a huge impact on death over the next year. And if you scale that by the difference in testing rate between the lowest and the highest testing shifts, you get a 32% reduction in 1 year mortality for the highest risk patients when they happen to come in on a high testing shift versus a low testing shift. So this is not a small effect. But because most patients are low risk, that gets swamped in the top regression and you miss it. So you'd conclude, oh, we're over testing, but you don't see this heterogeneity that the machine learning model can expose. So to come back to like the first question around the human machine interface in health, one model is automating the doctor. And I think there are a couple of reasons to be really, really careful about that. The first is that in our natural experiment, the highest testing shifts test well under 100% of patients. So we don't see what would happen if you tested 100% of patients. And because of private information, we're pretty sure we don't want to test 100%, even of the high-risk patients. We want the doctor to use their own private information over and above the algorithm. We do not want to automate the doctor. We also are just doing this for one decision of the testing for heart attack of the many decisions that a doctor needs to do in the ER. So this is pretty clearly an augmentation frame where you'd want the algorithm to give the physician some well-calibrated prior on risk and then let the physician update. And that's the basic insight behind the randomized trial that we're running now with a large health system where we're just cluster randomizing across hospitals and giving physicians access to the algorithm in some and not in others. But now I want to come back to this new way of looking at the role of ML in health, which is what can the algorithm tell us about the doctor? What can we learn from the algorithm? So let me caricature two behavioral models of the physician as a starting point. So the standard thing we'd want physicians to do is they see some distribution of risk in people coming into the ER. There is some tail of high risk patients in orange. And we want them to find that break-even threshold where cost equals benefit and test everyone above that threshold. The moral hazard view says, yes, physicians are testing above a threshold, but they're testing above the wrong threshold. The threshold is too low. And so you're going to get low average yield of testing, which has been documented in many, many settings, because physicians are dipping down into that purple group and they're not just testing the orange group. Here's the second view. Misprediction is also going to give you low average yield because now the high risk patients aren't in the tail of the distribution anymore from the physician's point of view. They're mixed throughout the risk distribution. So no matter what threshold the physician uses, you're going to get a mix of orange and purple people above the threshold for testing. So misprediction is going to give you low average yield. But misprediction has another empirical prediction, which is that there are untested high risk patients, which is what we're finding as well. So I think overall, the evidence here is that physicians are making a mistake. They are mispredicting risk rather than they are just following the incentives in a flawed system. So what is the nature of that misprediction? We are going to try to get some insight into that by looking at how physician testing decisions deviate from predicted risk. So this is following in a long tradition of clinical versus actuarial judgment. And we're specifically going to test two hypotheses. One is that physicians are using a too simple model of risk. And I think this is where we come back to that checklist question, which is that the checklists are 5 variables with integer weights. So if physicians are using something like that, that could just be too simple relative to the complexity of the phenomenon. And the other view, the Kahneman-Tversky view, is systematic errors and biases, where physicians are actually making mistakes because they're misweighting specific variables. So here's our way of looking at bounded rationality. We're going to use machine learning to create models of patient risk that vary in complexity. So we do this for a bunch of models in the paper, but the simplest one to think about is a lasso, where you've just got more or less non-zero variables included in your model of risk. So we're going to build and retain all of the models on the lasso path. And then we're going to see how well those models of risk, going from simple to complicated, predict risk as a check and physician testing decisions as a way to get in the physician's head. So the x-axis here is complexity as measured by the number of non-zero variables in the lasso. And the y-axis is R squared for two things: for predicting risk, which is in gray. And you can see this characteristic machine learning curve where, prediction gets better and better and better, and then it tails off as you start overfitting. So that's risk. The orange is the physician testing decision. So same curve, but you can see that the maximum occurs at very different points on that complexity axis. The best model for risk, the best linear model for risk in a lasso, has 224 variables. The best model for predicting testing has only 49. So R squared is a little bit, so here's a more formal test. We basically just regress the yield of testing on the simple risk predicted by 49 variables and the incremental risk that you get from the complex model. So we're just the difference between the complex risk and the simple risk. And what you can see is that the simple risk is predicting yield. That's good. When you add in the incremental risk, you get a bunch of signal for predicting yield. And you don't get any extra signal for predicting test. So I think this is just like a very concrete way of showing that that incremental risk estimate that comes from complexity is good for predicting yield and doesn't do anything for predicting the physician's action. So I think there are some really interesting things we can talk about more later, which is that there's an analogy to what humans are doing with the machine learning model, which Colin Kammerer has pointed out, that humans are actually basically good regularizers. We're good at honing in on a small number of variables. And I think that's what those decision rules, those checklists do as well. It's a small number of variables that the physician can focus on. But what we're seeing is very different from the traditional view, which is the clinical actuarial decision view, where people are just using too complex of a model. They're getting distracted by noise. They should just stick with a statistical model like a checklist that does better by being simpler. In fact, what we're finding is that physicians are using too simple of a model, and a statistical model does better by being more complex. And there's a really nice paper that is either coming out or came out in Econometrica on the illusion of sparsity that tries to model macroeconomic phenomena with simple versus complex models and finds that actually they're complex and you do better modeling them with complex models. So this preference we have for sparsity of models is kind of a human preference that doesn't really match the rest of the world. So that's some suggestive evidence, I think, of boundedness. But that doesn't answer another important question, which is, are physicians weighting those variables correctly? So we're going to take each of those models in the simple risk model, 49 variables, and we're just going to look at how they correlate with true risk, like the yield of testing on the x-axis, and the testing decision on the y-axis. And so, if those variables are weighted properly, you'd expect them to be tightly clustered around some line that's positive. And that's basically what we find. The R squared is high, they're pretty tight. But there are also some interesting outliers. So one outlier is patient comes in and says they have chest pain. So that has much more of a correlation with the testing decision than with patient risk. It's correlated with risk. It's on the right side of the graph, but it's way outside of the mass of all the other variables in terms of predicting the physician's testing decision. Age is similarly overweighted, and demographics like female sex and low income appear to be underweighted. So I think that suggests that there's, in addition to boundedness, some other stuff going on here, which is that symptoms and demographics are really standing out. That's the first thing physicians see about patients. And if you've ever looked at this medical education kind of material, it's like, this is the case records of MGH. The way you present patients in the hospital and education is a 54-year-old man with irritability, confusion, and odd behaviors. This might sound like someone but this is a case record of MGH, but they really hone in on demographics and symptom, and it's very salient. So we formed a test for this as well. So what we're going to do is we're going to use the same machine learning infrastructure we used to build our full model of risk, and we're going to restrict the inputs we're going to do the same thing, but we're going to restrict to only some kinds of variables. So we're going to form a risk prediction based only on symptoms, based only on demographics, et cetera. And we're going to ask, do those subsets of risk predict the physician's testing decision over and above the full risk score? And the prediction is that they should not. They are completely redundant with the full risk score. So the coefficient should be 0. But what we see is that when we regress the testing decision on the full predicted risk in the top row and the subset of predicted risk that just comes from symptoms, they are both significant. And in fact, the risk information from symptoms is larger as a predictor of the testing decision. And we see similar things for demographics, where they're overweighted, whereas this quantitative complex time series from lab results and vital signs appear to be underweighted relative to where they should be if the physicians were truly paying attention to everything. Now we can go one step further and form a risk score on the subset of symptoms that are like stereotypical for heart attack. So the symptoms that happen more often in people who have heart attack than the rest of the population, rather than just their contribution to true risk. And what you can see here is that the extra attention that physicians are paying to symptoms is coming almost exclusively from those representative symptoms. So I think this is a nice insight into the way that we stereotype based on salient symptoms like chest pain. So I hope I've convinced you of a few things, but one is that misprediction is a driver of low value care, both over and underuse. When we kind of add everything together and we generate a preferred estimate, we would end up keeping 38% of the tests that doctors are currently doing based on cost effectiveness, but we'd also add in a large fraction of patients that are not currently being tested. So it's not about over or under testing. Is the threshold too high or too low? It's about who's being tested. And I think that just echoes a bunch of recent literature on needing better models of physician behavior above and beyond just an incentive model. And so we complement that by focusing on these specific mechanisms of physician error. Let me end by just showing you one last concrete implication of this about incentives. So incentives is that's the one lever we have to affect physician behavior. But incentives can backfire in a world where physicians are not predicting risk accurately. So on the x-axis of this graph is risk as usual. On the y-axis is the testing rate. And I've just separated out the testing rate of the high testing shifts in our natural experiment versus the low testing shifts. What you can see is that on the low end of the risk scale, low testing shifts are cutting a lot of these low value tests. That's good. But they're also throwing the baby out with the bathwater. They're doing a lot fewer high risk tests as well. And we see the same pattern when we look at national Medicare claims. We recreate this whole pipeline. We look at high versus low testing hospitals, and we see exactly the same pattern. So humans shift up or down in a very coarse way, and they're not increasing the slope by any means. They're just moving up or down. They're not testing better when they test more or less. So in closing, I'll just say that I think a lot of the focus on machine learning in healthcare is about machine learning basically as a product. So a hospital can automate their radiologist by buying some software that's going to eliminate some of that labor, which is fine. But I think that misses another huge opportunity for machine learning, which is as a tool for understanding, where we can precisely identify these inefficiencies that get obscured by the average, and then find ways to correct them in real time, which I think we'll get some insight on from the randomized trial that I mentioned. And also just get better at figuring out what physicians are actually doing, what's going on in their head, beyond just thinking of them as incentive maximization machines. So let me end there and just note that the paper is coming out in the next QJE. It's a working paper at NBR. It's also on my personal website, which is just my full name.com/research, if you're interested in reading more.
Thank you, Ziad. That was a fascinating talk, I think, with a lot of tangible impact. To kind of manage the Q&A, if you'd like to put a question in the chat, I can convey it, or if you'd like to unmute yourself and ask, then we can kind of manage that with hand raising. Yeah.
I see there's one question in the chat from Bevan. So here, actually, Bevan, we are only doing the ER. So this is one, at least in the single hospital part of the paper, this is just ER doctors. In the Medicare data, we look at that across the whole country, but still restricted to ER. So we're actually just looking at decisions that are made in the ER. And we do that because that's the setting where the benefit of testing and treatment is most well documented. And so we are looking at the decision-making directly in the ER.
So one question I had, Ziad, going back to the basic setup, where we just have a threshold. I don't know how kind of easy it is to gauge expected yield, right, or expected return from a practitioner's perspective. So would there be another rule that kind of maximizes expected return rather than just thinking about a threshold?
So I think that the way I read the cost effectiveness literature that is voluminous in this area is that it's trying to map out basically from the randomized trial evidence and the costs and everything else, like how do you turn that diagnosing heart attack on a test into a more comprehensive calculation of return. But the reason that that's actually very distinct from what the doctor is doing is because the doctor is just trying to diagnose heart attack. And in this case, we're very fortunate that we have an empirical correlate to heart attack, which is when someone gets a test, does the test show a blockage? Because if the test shows a blockage, then you put a stent in it and then you record that as a treatment. So we are very lucky in this setting, and testing in general is a really nice setting for ML because we have this empirical thing that we can use as our objective function, which is you do a test, the test is positive, that's what you're trying to do as a doctor. So there's a very nice Nature paper from a couple months ago by Hamza Bastani at Wharton and her colleagues that optimized COVID testing at the Greek border in the early days of the epidemic. Similar insight where they're just using reinforcement learning to predict the yield of testing as a way to allocate those tests. So I think this is like a great use of machine learning that I think is going to be very, very impactful.
Got it. See, we have another question from Thomas in the chat.
Yeah, so Thomas is asking the great question of like, even so 49 variables still seems too complex. And one, there's a boring answer to this, and then there's a more interesting answer. The boring answer is that I wouldn't put too much weight on 49 because the way we specify the variables in our model is like, history of heart attack in the year before diagnosis, history of heart attack in 1 to 2 years before the ER visit, and things like that. So our own distinctions among variables is probably not the way the physicians are thinking. I think the physicians are thinking much more holistically about those categories that we break up into variables to squeeze more predictive juice out of the model. But I think you're exactly right that, even 5 variables, it's kind of hard to get physicians to kind of stop and put them into a form and stuff. And I think that the really nice part of ML is because all of the variables we use are observable in the electronic health record, we don't need the physician to, think about the variables at all. We're just pulling all of those data out and delivering one number to the physician, which is the likelihood of testing positive if tested for this patient. So this doesn't depend on the physician entering anything into a computer or paying attention or understanding or anything like that. Now, you might well need to engage with those issues to drive physician adoption. And I think we're taking a very behavioral view of what, how to drive physician adoption. But that's separate from the question of like, how do you get the risk prediction from the computer into the physician's hands? And I think that's much easier with an ML model with 16,000 variables than it is with a model with 5 variables, but that the physician has to fill out herself.
So we have one more question in chat from Victor about existing use of ML predictions for diagnosis. And then we'll move to Emma to ask a question over video.
Sure. And so, Victor, I'd be curious to know which ML predictions you're thinking about. I mean, to my knowledge, there are some early people biting around the edges, but I actually think that like largely I'm struck by the absence of many machine learning tools from the ER for predicting anything related to diagnosis. I think there's some stuff around like OR, like optimization of triage and queuing and things like that that you might be thinking of. But for diagnosis, I actually don't think there's much going on. There are some X-ray based things that, basically queue an X-ray higher up or lower in the radiologist's order based on the prediction of whether there's a serious problem on it or not. But those are not very widespread, and they certainly haven't been evaluated in any structured way. So my view of the adoption is actually that it's pretty minimal at this point, largely because nobody's run the trial to show that they work.
I see. I just wanted to say that this is just me trying to tell doctors, I know about your paper, and those people replied to me saying, but I have a computer in which I enter the symptoms of but I don't think this is proper machine learning. I think they probably don't know what machine learning really is, and this is probably the answer that you gave.
Yeah, I think that's exactly right. So I think people conflate like it's on a computer versus like what's going on the back end, and so most of the things are what the earlier question alluded to. There are checklists where you pull up a calculator and you input X's and Z's into the computer. And the reason that those can't be automated is because a lot of the things that matter are Z's, not X's. So you can't just pull them out of the EHR. You need the physician to enter them because you don't observe them. So that's the strength of the ML approach, is like you can just do this based on X, and that's why the integration into the workflow is so much easier.
Thank you very much.
Emma, you there?
Yes. Hi. I was wondering, this is a fascinating paper. I was wondering what would have you done anything like removing variables like symptoms that patients report when they enter the hospital? Because I think it would be very interesting to see if just prior risk could predict these outcomes, because there is so much variability in the way people present symptoms or say their symptoms. You might say, oh, I'm having chest pain, but you really just mean like, I feel weird, I'm having anxiety, or you might be really, afraid to say that you have chest pain, or you don't have chest pain, or you're having nausea. You wouldn't think to say that you have nausea because that seems unrelated. And so I was wondering if you ever removed those, could you still predict?
Yeah, really great question. And I think anyone who's ever been to the triage desk of an ER knows that, like, you go up, the triage nurse is like, what's going on? You say like, oh, I have this and this and this, but then the nurse needs to write down one thing. So which one the nurse picks is often, kind of completely arbitrary. And so there are lots of ways that particular variable can go wrong. Empirically, they seem to matter a lot for our prediction. And so I think that's because high-risk people can have chest pain or toe pain, and even given all of the problems with recording the thing, that makes a huge difference. That said, we do have in the paper these results in Medicare claims data, where we lose the triage information. We also lose the laboratory studies and the vital signs. We gain claims from other hospitals. So now we're only working within one EHR system. So it balances out a little bit, but we're still able to predict very well in the Medicare claims. And so they're important, but not deal breaking if not present.
It seems like the sort of thing that you could still, if your outcome variable is something like have any adverse outcome in the next 2 years, that even if you come into the hospital with toe pain, if you're like, I don't know, 60-year-old diabetic who is a certain weight, who is a certain, it actually might not be horrible, even if you're just coming in with toe pain.
Absolutely, yeah. And so I think that there's a really important point there, which is that there's a base rate of these bad events in high-risk people. And so we don't know what the base rate should be. The only thing we have to draw on is the clinical guidelines, which are dictating, like, what we think in a short period of time where the base rate should be low, what's the maximum we can tolerate there. And so that's why I think for me, the natural experiment was very, very important, because up until then, it's like you can quibble with a lot of things about the adverse event rate, including the contribution of the base rate. But when you see the natural experiment results and you're just comparing testing high versus low, I think that was the part that I found at least most convincing.
Thank you.
Great. So I think we're coming up on time. I want to thank you again, Ziad, and thank you all for joining us this week. And we look forward to seeing you next week on March 10th, where we'll be joined by Anjana Susarla from Michigan State University's Broad College of Business.
Thank you.